Hi, and welcome to Detours, Understanding Acquired Brain Injury. Today we're going to be talking about concussion. The thing about concussion is a lot of people seem confused about whether concussion is different from traumatic brain injury or acquired brain injury. The fact of the matter is that concussion is a traumatic brain injury. It's another word for it. It's a term that's been used, and it's an old term. It was used specifically in the 16th century. A French physician had described it and used the term concussion to mean a commotion in the brain. They hadn't made the necessary physiological changes that happen. But the fact of the matter is, it is a so-called mild traumatic brain injury. I mean, there's really nothing mild about it. It has serious consequences for a person who experiences it. And what's interesting is we're discovering that the symptoms, we used to think if you suffered a concussion or a mild traumatic brain injury, and I will be using the term mild traumatic brain injury kind of reluctantly, but I will be, instead of using the term concussion throughout this video and throughout the other videos that I will make relating to this, I will be using the term mild traumatic brain injury instead of concussion, because honestly, concussion suggests that it's, you got your bell rung, as you know, your coach might say, or something like that, like 20, 30, even some still say it today, but 20, 30 years ago, they'd say you got your bell rung, you know, get back in there and play kind of thing. Hopefully we've gotten better, but there's still some places where you might hear that kind of thing. And so it's important that we recognize the severity of it, and we'll be talking about numbers of persons who have it every year who suffer mild traumatic brain injury, and we'll be talking about definitions and symptoms and the long-term effects today. And then later we'll be getting into treatments and diagnosis, the use of CT scanners, MRIs, what they can and cannot tell you, and what alternative imaging techniques are available that show a lot of promise, because there's a very serious condition that can result from repeat concussions. And that's, you've heard that on the news, I'm sure, because a lot of famous athletes have this condition, but it also applies to amateurs, and even we're starting to see hints that high school athletes, or even in middle school, are showing symptoms of this condition, and that's known as chronic traumatic encephalopathy. Now, we've talked about encephalopathy before, but in context of other disorders, of other neurological disorders, but repeat mild traumatic brain injury can cause it. It's a tauopathy. And we mentioned that when we talked about the tau-based disorders, about how the cytoskeletons in neurons, and that's in the neuron video, are improperly broken down and can choke neurons and prevent them from moving their waste along and cause them to be destroyed. But again, that's something we'll talk about later in the video. So let's get into how you define a mild traumatic brain injury and what are its characteristics that differentiate it from moderate and severe traumatic brain injuries. You've seen those videos where we talk about the more serious types of traumatic brain injuries, but I want to make clear that just because we use the term mild does not mean that its impacts, the ways it changes lives, are not just as serious, just as severe. Mild refers more to, quite often, the fact that the person may not have been rendered unconscious, or was only unconscious for a brief moment, or that the skull was not broken. But the neurological symptoms, the sequelae, are just as bad in many cases. In some cases, have psychiatric symptoms that are worse, because the person who's experienced this type of an injury knows what life was like before, remembers it, and hasn't had their memory kind of wiped out. And so they look back and say, why can't I do what I did before? So I want you to keep in mind as we go along here that a mild traumatic brain injury can be just as serious, if not more serious in some cases. And so the questions we'll be asking as we move along here are those kind of things like, what is it? How do we treat it? What are the long-term ramifications? What are the imaging technologies? And finally, what does the future hold for treatment of mild traumatic brain injury? Okay. Now, for a mild traumatic brain injury, the American College of Rehabilitative Medicine, who's kind of the authoritative body on this kind of things, because physiatrists, rehabilitation medicine physicians, are typically the ones who will be handling rehabilitation. They often will look at a couple different factors, and one of them is the Gloscal Coma scale. We talked about that back in Disorders of Consciousness, and you're looking at a GCS scale between 15, which is what we are typically every day, you know, fully awake, our motor skills, our speech is 15, down to 13. And there may be meaning a slight deficit of either motor skills or speech, but mostly still fairly oriented, just a noticeable deficit in either how we move, how we react to pain, how we talk and respond. But so that's still a fairly high score, but it's suggestive that there's a problem. So 15 to 13, if your score falls in that range and there's something else showing, yeah, it's likely it's a mild traumatic brain injury. All right. Also, loss of consciousness from 0 to 30 minutes. So if you've lost consciousness for up to 30 minutes, it still falls the rehab physicians, the physiatrists, and the nurse practitioners who practice rehabilitative medicine say from 0 to 30 minutes of lost consciousness, it still falls within the range of mild traumatic brain injury. An alternative to that is an alteration in mental state, as opposed to simply being unconscious, where you kind of feel weird, like dazed, foggy, confused. This could be from not at all the way up to 24 hours. So if you're feeling confused and disoriented, or kind of from just a couple minutes to 24 hours, you still fall within the classification of mild traumatic brain injury. If it's more than that, or if your loss of consciousness is longer, then you move into that moderate category, where we're starting to be much more thinking that this is going to be somebody with potentially the more traditional type of brain injury that you see on television, or, you know, like the soaps or whatever. But it's important to remember that a majority of people who suffer traumatic brain injury are diagnosed with so-called mild traumatic brain injury, this type of injury, that the 75% of people who have traumatic brain injury have this type, and that a much smaller minority of people have the moderate and severe. Now, I was diagnosed with moderate traumatic brain injury. My GCS was around 9 at its worst, so I was almost in the severe category. But again, you know, it's like these terms are used to help physicians, and so it's important not to get stuck on the language. Okay, it's really important not to get stuck on the terms and the language. Okay, so I just wanted to stress that. So if you're one of those people who are, it's like, well, that's really doesn't describe me, I don't think that's right, don't get stuck in the language that the doctors use, because what the physicians use to communicate is really meant from doctor to doctor, and they know what this means. They know that, yes, it's still serious. There are also things to keep in mind is post-traumatic amnesia. So if you have a loss of up to 24 hours from the point of the injury to up to a day before, if you're missing your memories from that period of time, then at that point, you know, again, we're still thinking mTBI, but if it stretches longer again, then you start to wander back. So many people who will take the hit to the head for an mTBI will say, I don't remember the accident. Maybe I don't remember, you know, up to yesterday. But if it's longer than that, again, that's hinting that we're looking at moderate. And of course, if it's significantly longer, then severe, and the person's unconscious for, you know. But a person with this mild traumatic brain injury has, typically it extends within 24 hours. And so that's the defining range for that. Finally, normal imaging. This one's kind of a little tricky as the scans have gotten better and as MRIs have improved, but this area, for the most part, we would say that mild traumatic brain injury, you would look normal on a standard CT scan. A standard MRI will show no damage. So you have so-called mild traumatic brain injury. Because initially it's physiological damage, it's a disrupted neurotransmission. There is some physiological damage. You will see diffuse axonal injury typically, but what can be seen and resolved, even good scanners for the most part right now today, is typically not the kind of thing that you would see in mild traumatic brain injury. You need a moderate or severe injury to see some of the significant changes. So for mTBI, mild traumatic brain injury, or mTBI, you would typically not see on a CT scanner or an MRI yet. I'm suspecting in the next decade or so, we definitely will start to see changing in what we can image and detect. But for now, a negative CT scanner MRI. The CT scanner really is used to find neurosurgical emergencies, swelling, bleeding, midline shift, all of those things suggesting that you have to go to the OR right away, neurosurgical intervention. And that, even with moderate TBI, you don't see a lot of that kind of thing. You usually more often see that with severe traumatic brain injury where neurosurgical intervention is necessary, or cerebrovascular accidents, or AVMs, where you get bleeding into the brain. So typically, again, you might in the most severe moderate brain injuries, but typically that's severe traumatic brain injury, but you will not see it in contemporary MRIs or CT scanners. To detect them, typically neuropsychological evaluation is necessary, and that's specialized testing by a trained psychologist, clinical psychologist, who has extra years and certification, postdoctoral cert in giving batteries of tests. So that will detect the typical symptoms, the sequelae of mild traumatic brain injury. The detection of certain focal deficits, which are transient, but they typically are things that we'll get into, short-term kind of things. They'll last for up to about 3 months, and we'll talk about those. And there are people who then had developed something called Post-Concussive Syndrome. That we'll get into in a moment here, but I want to talk about the transient symptoms you see, okay? Now, the mechanism behind mild TBI, typically, let's imagine either whether it's a football player, tackling somebody or being tackled, or whether it's a car accident, which is very common. Usually it is a sudden acceleration and a sudden stop. And that sudden acceleration and stop shakes up the brain. And there is a forwards and a backwards movement of the brain inside the skull. And as you can see, the inside, this is molded based on a real skull, by the way. You can see that the inside is not a friendly place, considering that you can see these sharp edges on the inside. It's not a friendly place for the kind of speeds that we're dealing with when it comes to things like driving a car, riding a motorcycle, airplanes, any high-speed activity, or playing football. Or heading soccer balls, because incoming impacts also affect the brain in the same way. And my favorite brain model here, certain areas are more likely to be affected when the brain is shaken forwards and backwards, when it comes towards you and backwards. And most typically the frontal lobes are what are impacted, as well as the occipital lobes here in the back, as well as also the temporal poles. When this happens to somebody, it affects a lot of different things. The temporal lobes deep inside there are structures for memory. And this is part of why a person who suffers a mild traumatic brain injury will have memory deficits. They'll have processing deficits. Their speed of thinking will be slowed down. They get headaches and psychiatric symptoms many times. These are more typical initially to begin with. And that confusion, because the higher cortical areas, the areas that do the in-depth thinking, are here. And these are areas associated with problem solving, associated with attention, focus, in the dorsolateral, up here, in this region here, creativity, emotional regulation, behavioral control, like inhibition of inappropriate behaviors. If those areas are impacted, you would have a person who has trouble, for example, focusing to pay bills, or focusing to solve a math problem in class, or a person who says whatever's on their mind if they lose control over that inhibition, or may act out emotionally. They may hit somebody if they are angry over something mild. They may be sexually disinhibited. And yes, these are sequelae of so-called mild traumatic brain injury. That is why it's important to understand that even though it's called mild, the effects can be very serious. Again, with the temporal poles here, this area right here, a lot of integration between the limbic system, which is deep down and provides for emotional input, and frontal lobes, which provide for that kind of regulatory behavior and helping make sense of the emotional world. Damage to these areas can affect a person's feelings and how a person understands the emotional world around them. So it also, the temporal lobe processes sound and language, and so damage here again can affect speech and the ability to communicate and talk. So yeah, it's important to understand that there are potential for a lot of different side effects from traumatic brain injury. The occipital lobe on the backside processes visual information, not just to see, but also to recognize objects. And so impacts there may affect someone's ability to see three-dimensionally, or to know what a key is, or what a door for your car is. And they may only be able to recognize partial objects, even though their eyes work just fine. So you can get effects. Now, the pathophysiology behind it is that neurons are pulled, stretched, and twisted in the process of being thrown forward in an accident, because the brain is soft and gelatinous. So it'll twist, pull, thrust. And as it does these things, it destroys the neurons in a process called diffuse axonal injury, which I have a video that talks about that in the pathophysiology and neurons, where I talk about diffuse axonal injury. Axons are part of a neuron, and they, in what are called white matter, are myelinated. They're insulated, basically. And stretching of the axons can disrupt their ability to move nutrients around the cell. And doing that will cause them to die over time. They'll starve to death, basically. And so over a couple months, you may notice a person's skills. They may be, when they wake up or become aware, they may be going along, and then suddenly their skills drop off. And that's because, or their executive functions or emotional regulation or whatever drops off. And that's because those neurons that were starved finally die. That's encephalomalacia. And there are 3 levels of diffuse axonal injury, or basically white matter death. One, which is the mildest, that's just isolated to one hemisphere, to just one side of the brain, and depending on where, many times just one lobe, like frontal typically. Then there's grade 2, which is communication across the hemispheres, which is the ability of brain sides to work together. And 3, where it affects the corpus callosum, which is a bundle of white matter deep inside the brain that, excuse me for a moment, that affects here the ability for the sides of the brain to communicate here. There's a thick bundle of white matter that allows, now that does include some of grade 2, but grade 3 is all over the brain. And so that is where you'll see prolonged unconsciousness, deep confusion, deep difficulty with skills arranging all across human function for that. Obviously, grade 1 is the most typical, but you can see grade 2 dysfunction as well, where you have trouble with coordinating between different areas of the brain. And so you have broad-ranging skill dysfunction, like trying to do mathematics or read or write. Again, yes, these can be symptoms of mild TBI, and that's again why I said mild TBI is probably a misnomer for this. You also get something called excitotoxicity, where basically too much of certain excitatory neurotransmitters, which send the signal from one neuron to another, are released so frequently and from the damage, and they cause the gates to open. See my video on neurons. And they become flooded with the calcium and the sodium that are needed to fire off neurons, that it kills them. It basically poisons them with calcium and sodium, that it kills neurons in large numbers. So that's another way that mild traumatic brain injury is destructive. So these are some of the mechanisms. So physical tearing, straining of the neurons, a diffuse axonal injury where the stretching and the tearing causes damage to the transport networks inside the cells. They're basically the pipes, if you will, and it causes the neurons to die. And finally, excitotoxicity, excessive stimulation of the neurons, causes them to die also. So that's how it works. There's some interesting research that I've always thought was important to stress, and that is that women, while men get concussions or mild traumatic brain injuries more often, women seem to suffer more devastating effects. And that's new research out of Stanford. They noticed that there's even more cortical thinning, so the layers of the cortex thin in women who suffer. And it seems to be for a couple different reasons. First of all, while estrogen is protective if injected from outside, it seems protective of men, it actually seems to act more like a poison for women for some reason. Not understood why. And it's still a fairly small study, the effects of estrogen, endogenous estrogen. So who knows? But two other factors. One is that women have a smaller body mass on average. Yes, there are bodybuilders and things. I'm aware of that. But on average, women have a smaller body mass and therefore more energy if they take a blow or a shake or something should happen. And yes, domestic violence, sadly, is the leading cause of traumatic brain injury in women. So that more energy is delivered to their brains when they suffer a concussion. And what that means, therefore, is that with more energy delivered, more neurons are killed and they suffer more destruction. The other thing is that their neurons are thinner because smaller body mass again, and therefore they're more likely to be torn under shear strain, under stretching, pulling, twisting. So they're more likely to suffer permanent damage as a result of traumatic brain injury than men are because their neurons. And finally, there seems to be a difference between the ratio of gray matter to white matter. Now, gray matter is more densely packed neurons with their soma, the bodies of the neurons. So they're more tightly packed together versus white matter, which are like the telephone network between the different areas, the different nuclei. So women have these thicker bundles of white matter, which are used to communicate from different areas. So they're better, women tend to be better, at least according to these theories, at linking different areas of their brain together, more efficient. And so that helps them with more integrative kind of thinking. And guys are better at like isolated specific skills. And the research seems to bear some of this out based on neuropsychological testing and imaging studies. The difference is very small, but is statistically significant, and that's important to acknowledge too. So it means we'll have to approach treatment of women differently, be more aggressive in trying to protect their neurons, perhaps glutamate blockers, try to do things that protect white matter more effectively in them, Obviously, domestic violence mitigation, be more aggressive in protecting women against abusers, things like that. Obviously, we'll have to be much more assertive in that as we find more evidence that proves. I mean, it's not like we shouldn't have been, but this is something really important. We also will need to find if there are estrogen blockers would help if this study bears out. So there are certain things that we will need to do. Maybe make sure that that the airbag does not blow out like it does fast. Maybe a slower accelerating airbag, because hits to the face from the airbags when they go off in a car crash have been shown to cause mild TBI also. So that's kind of the mechanism also behind how mild TBI unfolds and the damage it does. Long-term symptoms that you see with mild TBI include things like neurofatigue, which is an extreme kind of deep tired. I get that. And you see that for people with traumatic brain injuries across the spectrum. It isn't just with mild traumatic brain injury, but it is this kind of extreme mental fatigue. And this is not just your I'm tired of looking at the computer all day kind of tired or from work. This is a tired that is throughout all areas of concentration, focus, all of that. You also will see, as I mentioned, frontal release. Frontal release is where you see symptoms caused by frontal lobe damage, the disinhibition that I mentioned, and emotional lability, which is where the emotions are something I have, where emotionally you switch from happy to sad to angry very quickly. And sometimes you'll get deep depression or, in some cases, complete disinterest, no emotion at all. Now, what's important to differentiate on that one is that in some patients, they do have emotion, but they can't express it. And they actually feel upset, happy, sad. They just seem not to show it on their face. That is treated differently, and you need to actually see how the patient reacts. Other people have what's called Pseudobulbar Affect, is where they display an inappropriate, mismatched emotion to the condition. They might laugh at a funeral or cry at a birthday party or something like that, which is not congruous with how they're feeling. There are medications to help that. But it's important to try and figure out what exactly they're reacting to. Frontal release is a lot harder to treat as far as, you know, inappropriate behaviors. They're very childlike sometimes. They can, a person, I mean, typically what it is a question of degree, how serious it is. Many times it may be just a mild, other times with more severe kind of injuries, you may have this to an extreme, but a person with frontal release may be not care where they cuss. They may they may punch somebody that they, you know, punch a cop or a friend, or may hit loved ones and caretakers without considering the long-term consequences of their actions. Very much like a kid. They also may look like ADD, ADHD sufferers in a lot of ways, and those medications actually can help. Many people with mild TBI, the long-term consequences of their condition, their symptoms, they may have trouble with their visual skills. This is not unusual. Again, that forward, backwards, the frontal and the occipital impacts. Their eyes may get tired quickly when reading a lot of text or when looking at the screens, things like that. So sensitivity to that, maybe making sure they get off their devices. They may just become, again, and tied into that fatigue, they may not be able to last too long. So occupationally, that may affect people who are connected to the screen all the time. It's like they may need frequent breaks. So that's important to keep in mind also. And people who are, again, that disinhibited, maybe a standard office environment isn't a good place for them, although they still need to learn how to re-socialize. So stepwise re-engagement over time is important. And so headaches are very common also. People with mild traumatic brain injury get headaches. I do. But that applies again across the spectrum. Migraines are very typical, tension headaches, and with the symptoms that typically come with that. it's important to get them to a headache specialist to help them out. Many people with mild traumatic brain injury have problems with balance. They're more likely to trip, stumble, fall. They have problems with uneven surfaces, with like on grass or, versus rocks or on sidewalks. They have trouble with coordination. They may not be able to catch a ball. They may have trouble with writing or other things that require, again, coordinated, smooth movements. And they may have trouble with a lot of the skills that they had before that required coordination. They may have trouble playing an instrument. They may have trouble playing the piano. They may have trouble with any sports that they did before. Because, again, these motor areas in the brain have been affected, and the ability to plan and coordinate here in that frontal area and back further, which is still considered frontal, but in these regions where motor programming is performed, those areas can also be affected. And so it's important to consider that those areas may be impacted. Not to mention, there are other systems that when you're in an accident or injured, your inner ear, and you may also have your third or your fourth cranial nerve. These are nerves that come out, and you can see here some representations of them here, up and down here in the white section, where I'm pointing not well because this thing is backwards. Here, where the cranial nerves come off of the brainstem, and those travel down, and some come off the cranial plate, and some coming here. And those control, for example, your tongue, control your eyebrows, your eyes, other areas. And if those nerves are damaged, it will affect other things. Many people who have brain injury will have ptosis, and drooping of the eyelid. I get that when I'm tired. They'll have drooping of the upper lip, Bell's palsy, and that's due to damage to cranial nerves, which also is something that kind of shows they're having some kind of injury to their face and to their head. Sleep problems, very common. People with all kinds of traumatic brain injuries have sleep problems, and so melatonin can be used to help. There are stronger medications. Trazodone is commonly used to help because they may have trouble either falling asleep or staying asleep. Staying asleep is a fairly common kind of problem a person with traumatic brain injury has, because they have problems with both their pituitary many times, and they also have problems with hypocretin, and which is one of those internal hormones which keeps you asleep and helps regulate that sleep. And then, of course, there's the melatonin. And so you want to do things that promote good sleep hygiene. So turning off the electronic devices, making sure you're in a comfortable, well-ventilated room, comfortable sheets, that you're not too sweaty, you're not too hot, you're not too cold. Make sure the air is moving, all those kind of things to help. See a sleep specialist. Make sure that if you have sleep apnea, that is treated properly, either with a CPAP machine or surgically. There are surgical interventions. And finally, there are dentists who have special appliances that they can give you to help with that too. Now, PCS is an interesting kind of thing because a lot of people who they suffer repeated blows, and when you're dealing with PCS or post-concussive syndrome, different grades of concussion may leave you with permanent symptoms. If it lasts more than 3 months, you're probably looking at long-term. If you haven't resolved by then, you're looking at a year, maybe 2 at least, and possibly indefinite amounts of time. It may be permanent. About a quarter of the cases, maybe a little more, seem to be permanent. We didn't used to acknowledge that, but the old name for this was post-concussive syndrome. Now they're calling it persistent post-concussive symptoms, and there's a reason for that. It's not to disacknowledge that they are permanent symptoms, but what they're getting at is the fact that a syndrome is a specific cluster of symptoms that are seen all the time that tell you that this is this disorder. And the problem is each brain is unique. We don't all have the same symptoms. Some people may have executive problems. Some people may have language problems. Some people may have problems reading. And some people may have balance problems only, and some people may only have visual problems. And so you can't say that this group of symptoms is indicative of mild traumatic brain injury, and this group of symptoms over here is not. So it's better to call it, persistent post-concussive symptoms. So it's still the same letters. So, PCS and add an extra S. But it does indicate that a person with mild traumatic brain injury has lasting, it's permanent symptoms associated with their mild traumatic brain injury. And about a quarter, it seems like about a quarter, maybe a little more, of persons have permanent neurological damage from their concussion. And so what are the risk factors? I'm going to talk about the risk factors, and then I'm going to close this out. I want to talk about the risk factors for PCSS. Typically, you will find that a person who's more likely to have this persistent post-concussive symptoms is likely to be older than would be, the average. So an older person is more likely to have persistent post-concussive symptoms. They're also likely to show psychiatric symptoms. So if developed as a result of this disorder, they're more likely to be depressed or have anxiety following their injury. And we know that is possible due to frontal lobe injury, that you develop depression or anxiety. So I'm not saying it's a primary that you have anxiety or depression first, then have the injury. Instead, what I'm saying is if you have anxiety or depression as a result of your brain injury, it indicates that it's probably going to be more persistent because it's a frontal lobe symptom, and those are more difficult to resolve. Repeat injuries. Chronic traumatic encephalopathy, which is not well understood, but I'll talk about that briefly. Polymorphic genetic anomalies, certain gene problems. So I have to look at this for a moment. The ANKK1 and the APOE4, that is associated with Alzheimer's. So if you have the gene associated with Alzheimer's, your risk of having persistent symptoms associated with mild traumatic brain injury goes up. And that kind of makes sense. The tauopathies that I had talked about before. If your neuroimaging is abnormal in some way, which kind of makes sense because that means you're leaning towards a moderate traumatic brain injury there, and a rather serious one. So yeah, definitely a red flag. If you have extracranial injuries, if things other than your head are injured, if you've got other body parts, it means you receive more energy to your body. And so if you also have a lot of extra initial symptoms, if you've got, transient neurological abnormalities, if you had a loss of consciousness, if you were confused, if you had the amnesia, if you had all of these things, yeah, there's definitely a darn good chance that you're going to have post-concussive symptoms that last, PCS or PCSS, persistent post-concussive symptoms. Yeah, so keep that in mind, that these are the kind of things that are red flags. If you're genetics, these are all red flags that you likely are going to continue to have permanent symptoms if you have any of these things. Also, just on the being cautious side, if you as a provider know that they're suing, it's important to understand that that is also a risk of them demonstrating symptoms. I'm not saying that to discredit anyone, but it is important to know that when we're dealing with testing and assessment, neuropsychological testing and assessment, that it's important to screen out people who may be exaggerating things a little bit here and think, maybe I can, even though I'm better, I can get a buck out of it. Fortunately, there are tests to detect malingerers, people who are faking it. And there are ways in neuropsychological testing statistically to tease out scores that don't make sense. And so that's one of the ways. So finally, I want to talk about CTE. Not well clearly defined yet. CTE, chronic traumatic encephalopathy, is, as I said, it's what's called a tauopathy, because the tau proteins are what are broken down by the mitochondria, and they are the kind of the waste products at the end after, as the cytoskeleton which supports the cell is broken down, and sometimes it's broken down incorrectly, and it is basically toxic to the cell. And it seems as though repeated blows to the head, repeated mild TBIs over and over, like from, say, getting tackled a whole bunch, or domestic violence, repeated blows to the head, accumulate this toxic waste product and cause the neurons to die. And it's progressive. It looks a lot like Alzheimer's disease. There's, in fact, the difference between the tau proteins associated with Alzheimer's and with CTE are virtually indistinguishable. There's subtle differences, but for the most part, they're pretty much the same. And you get the same kind of symptoms. It is progressive. The disorder, you start with some of the same kind of memory problems, forgetting, getting lost, your geography, your sense of location is disrupted, and then you start to get behavioral symptoms over time, and eventually you start to forget loved ones, and, you know, it's the same kind of pattern. You get the sundowning, and eventually you become completely dysfunctional, just like in Alzheimer's, and die of usually some secondary infection, pneumonia, or inhaling food that you have or whatever. And unfortunately, that is the only difference is more aggression, perhaps, but it's still, again, not clearly defined. And I do want to have a separate section on CTE, but it's difficult to say because it can only be determined after autopsy at this point. There are some promising new imaging techniques which may lead to better treatments. The only real medication we can give is Aricept, which is used for Alzheimer's victims. It is an acetylcholinesterase inhibitor. Realistically, right now, there isn't too much we can do. The thing is, doctors are reluctant to give a diagnosis more than provisional because we can't determine it, whether you actually have it, till we've done an autopsy. So for now, we just say, provisional, but the symptoms look a lot like Alzheimer's. And just like Alzheimer's, you can last for a long time, or it can be a short time from first provisional diagnosis to when you die. And so on that happy note, I'm going to be closing out here because this is probably one of the more important videos I've done on concussions or on brain injury in general, but there will be more on this topic later, but I just felt this was an essential one. So thank you for watching Detours. Please click like and subscribe if you like this content. Don't forget to click the bell icon, and we'll see you later. Bye.